Welcome, everyone. Glad you could join us this evening for another version of our Midwestern Vascular Surgery New Horizons webinar series. I think many of you know me, but my name is Ross Milner. I'm Chief of Vascular Surgery at the University of Chicago and also President-elect of the Society. I'm honored to be joined by Dr. Ines Chiassa this evening as my co-moderator, and we would both like to thank all of our speakers who will introduce individually in a few minutes here as they have an opportunity to present, but as well really would like to say thank you to Shockwave as our industry partner and sponsor this evening, with a real focus on how to manage some of the challenges we see with aortic occlusive disease and access for large bore devices for aneurysm care as well and dissection care and as well as peripheral vascular disease. So hopefully it will be worthwhile for everybody. We'll try to make sure that we leave time for questions. All the speakers think that they are good on time, and I'm going to turn it over to Dr. Chiassa.
Thanks so much, Ross. And again, welcome everyone. Honored to introduce our first speaker, Dr. Talia Weiss, vascular surgeon and service line medical director at the Marshfield Clinic in Marshfield, Wisconsin. Hugely successful, great friend of mine, interested in both thoracic outlet syndrome, carotid disease, and all extensive vascular disease. So I'm going to turn it over to you, Dr. Weiss, to kick us off. Thank you.
Thank you for the lovely introduction. I think I've got can you guys see my screen?
Yeah,
Okay.
you're great.
Yep, you're great.
Excellent. Thank you so much. So my name's Talia. I was asked to present on, are there things that are too heavily calcified to treat, or is shockwave and lithotripsy obliterating the need for basically open surgeries? So I have a couple of disclosure. I am a consultant for Shockwave Medical. A couple of didactic slides. So as we all know, atherosclerotic disease is worsened by certain comorbidities, and the plaque development actually changes depending on the anatomic location. So more specifically, intimal calcification, generally associated with traditional cardiovascular risk factors, obesity, cholesterol, and smoking. These are the things that we learn about in medical school. You know, you've got your macrophages and the diapedesis and the migration into the intima, and then the foam cell formation. So generally affects medium and larger vessels. It does affect the internal elastic lamina and ultimately can lead to stenosis and occlusion. Medial calcification, also known as Munkenberg's sclerosis, is generally associated with age, diabetes, uremia, and certain enzyme deficiencies. There's elastin layer disruption. There's actually a very clear association of calcium formation within the smooth muscle cells. It usually has to do with transformation of osteoclast-like cells in that layer. Oftentimes seen on x-rays as that railroad tracking. So if someone gets a foot x-ray because their foot is red and people think that they have maybe some osteomyelitis, but we all know it's dependent rubor, you'll see the railroad tracking of the calcium, the tibial vessels. Also more common in the small and medium-sized vessels, and then the advanced form leads to increased arterial stiffness. Really briefly on CAP morphologies for patients with CTOs, classifications generally 1 through 4, and it can dictate how you approach a lesion, whether you want to go antegrade, retrograde, subintimal, or both. These are a couple of case presentations that I have. So generally, the patients that I often find that we have the most difficult or limited options to treat are, diabetics, patients with chronic kidney disease, and then in our patient population, in our region, the north central Wisconsin, large patients with BMIs often exceeding 50. This is a patient that presented with forefoot gangrene. The ABIs and toe PPGs were essentially completely flat. I did a radial access CO2 angiogram just to try and elucidate more. You can already see the railroad tracking, but really the inflow and infrainguinal vessels were pretty clear and clean, and then there's just essentially no tibial runoff. So for this particular patient, I didn't want to endeavor on groin exposure, so I did mid-distal SFA exposure. These were the angiograms. And then using antegrade retrograde access, I was able to recanalize the PT. So this is use of a 2.5 shockwave back when they were the 40 millimeters. And so I think I used 3 balloons because that's how many shocks that you have. And then you can see when I post dilate it with the 3, you can see all of these lovely little wastes. I call this the sausage, which means I was too impatient pulling back on the shockwave. So then you go back in with maybe perhaps a slightly larger balloon and repeat the process, all of which was very tedious with the 40 millimeters. And this was the patient's pre, and then this is their post. So it's a wonderful tool in our armamentarium to be able to treat this tibial disease, especially when patients are very high risk for a bypass, especially when you don't think that they actually have a vessel to plug into based on an antegrade angiogram. The patient underwent a partial transmet and then essentially healed, but would always open up whenever his swelling got out of control. So I have another patient, a type 1 diabetic on dialysis, presented with CLTI with gangrene, and had a transition within a month of present toe pressures to essentially completely flat. Again, exposure and then crossing with a wire to do the shock wave. This was infrapopliteal. The knee is about here. And this is the pre, and this is the post. And another patient, for some reason, we often have octogenarian and nonagenarian service in Wisconsin. Our patients seem to live forever. I don't know if anyone else has that. It must be the air up here. But a woman that came in, multiple previous endovascular revascularizations. We didn't want to do anything open on her. And she essentially presented with gangrenous ulcerations of her digits. This is her popliteal, maybe to an anterior tibial. I tried to pass a wire antegrade and was unsuccessful, I think, because of the bend of the origin of her AT. Usually I'll try for about 1 to 3 minutes, and if I can't, I'll stick distal and go retrograde. So here I was able to, you can only do this once. So of course I'm going to show the video, pass the wire directly into my catheter. And then this was her post. So although I'm a frequent user of intravascular lithotripsy, we all know that there are plaques like this that exist in people's vessels. And oftentimes if you're pulling it out with a peon, or if your fellow reaches for the met and tries to cut through it, the met doesn't cut through, and then they grab your blessed coolie scissors and then destroy your coolies trying to cut through these plaques. And then, regardless of any kind of treatment, you still have to be able to get a wire or get access across the lesion. So this is a mid SFA cut down. I can't even get a needle through it. It was bending my needle. So there are situations where I do think that the calcium is just too dense to be able to treat. And again, being able to get wire through a lesion successfully is always going to limit our ability to treat them. So we've all been in that situation. So that's all I have. I'm happy to take any questions unless you guys do want to wait until the end.
Yeah, Talia, that's great. Thank you so much. And just as a reminder, to Talia's point, there's Q&A that you can use. We'll try to pay attention to the chat as well. We do have time for a question or two if anybody has questions. So Talia, you brought up the point of when is it too much calcium, and obviously that video you just showed where you can't even put a micropuncture needle in there is a pretty good example. But as you think about different patients, and you talked about the body habitus, but when in your mind do you make this decision between I'm going to do a very extensive sort of endovascular intervention, or consider just doing a surgical bypass for durability reasons, and how do you? I realize it's not like an obvious, I do this every time this way sort of question, but how do you make these decisions?
So I generally will always try endo first, even if it means arm access. And honestly, I'll try for about 1 to 3 minutes to go antegrade, and then I switch really quickly to pedal access to try and catch and snare a wire. And that's been pretty successful. In the rare cases that it's not, it's probably, 20-30% of my cases I really can't get through. And then those patients are bypass candidates. I do think it's really important, though, to stick the foot and do a retrograde angiogram to actually determine what the runoff is, because you may never get a clear picture from an antegrade angiogram. So.
Great. There is a question from the audience, actually, wondering if anybody on the panel has experience with Javelin yet, and when do you think it's most useful?
I actually was a PI for Javelin, and it is useful when you finally get that wire through. And although the shockwave balloons have a really low profile, and I think that if you have through and through access and you have a really tight rail, you can usually push it through. On those rare occasions where you can't, the Javelin will actually really help create the path so that the shockwave or any other treatment methodology can actually use the rail.
So you would not use Javelin to cross, if I'm hearing you correctly. Your kind of recommendations is
still need a wire.
Get a wire across, then get the Javelin to help you create that channel to be able
Yep.
to advance your subsequent treatment modality.
I think I have a couple of slides on that. So.
Oh,
Great.
great. Wonderful. Well, any other questions, feel free to drop them in the Q&A. I'm sure more will come up as we keep going, and some may be answered along the way. I'll turn it over to you, Dr. Milner, for our next speaker.
Great, thank you. And Talia, again, great talk, and thank you very much. And thank you for being punctual. We appreciate that. So our next speaker is Vipal Ketarpal from WashU. He's an associate professor of surgery there, did his training there, and is intimately involved with the limb preservation program, and has a huge interest in CTLI. So thank you for joining us this evening.
Thank you, Dr. Milner. Can everyone see my slides? Let's see.
See your slides. We just got to get in presentation mode.
One second.
Yep, no problem.
It stopped working. So sorry.
No problem.
No
It's
problem.
always so much fun when we do the practice runs in advance and it works perfectly. Then you get to do it live and it doesn't work.
Okay. Can you see it now or not yet?
Yeah, just you're close. Just there you go.
All right, perfect. Well, thank you so much for this opportunity. I do not have any disclosures. I'm going to be talking about best practices for tibial calcific disease. As we all know, there's a lot of tibial calcification in patients with CLTI. Almost 80% have significant calcific disease in these segments. A lot of these patients are diabetics, have CKD, have significant smoking history. So two kinds of calcium, intimal calcium inside the blood vessel, and medial wall calcium, which is actually even more concerning for optimal treatment outcomes. So as you run into extensive calcifications in these tibial segments, there's a higher preponderance of technical failure associated with these calcifications, and overall event-free survival decreases over time as you look at patients who have significant tibial intrapopliteal vessel wall calcification, particularly the medial wall calcification. So specific challenges with the BTK vessels when it comes to calcific disease is that generally these vessels are smaller in size. More often than not, they have more occlusive disease with CTOs rather than just local stenosis. And oftentimes these lesions can be really long and tortuous, which makes crossing and treating them very difficult. And as I mentioned earlier, deep calcium is an independent marker and puts them at risk for amputation. Our bailout options for these segments are also limited. Outside of proximal tibials, generally we try to avoid putting stents in. So it gives us less flexibility as to what we can do with these vessels and managing complications like perforations. So how to get the best outcomes when you're dealing with calcified tibials? I think it has to be divided into 4 different things. We have to be very methodical about our patient selection, their medical therapy. It's important that we pay attention to the tools we use to cross these lesions, because Our ability to cross these lesions in true lumen actually gives us the best outcomes for these vessels. They tend to dissect a lot. We tend to lose them with thrombosis. We can perforate them. So crossing them in true lumen is very key. And lastly, vessel modification, since our bailout tools are limited. So in Basel II trial, when they looked at BTK vessels for vein bypass and endovascular treatment, the limb events were similar, but the survival was a little bit better in the best endovascular treatment group. But if you look at the graph to the right, you can see that this graph could very well be a graph of metastatic cancer, with about 10% people dropping off every year and dying from this disease process. So I think while we try to focus just on vessel patency as vascular surgeons, I think it's very important to also note that these patients are sick and they do poorly when we do not pay attention to their medical treatment. In Basel II, about a third of the patients were not on the best medical treatment, so to speak, lacking some statin therapy or antiplatelet therapy. So making sure that we focus on, say, low-dose Xarelto for Voyager trial, or making sure they're on a good antiplatelet regimen and good statins. If they can afford PCSK9 inhibitors, the results from all the studies for CLTI and PCSK9 have been phenomenal. So how do we ensure that we cross these things in true lumen? As Dr. Weiss mentioned, we have to get comfortable with alternate access. Pedal access, retrograde access is key in some of these cases where we are not able to drill through from the top. We need to expand our toolkit and start using more specialized CTO wires and catheters, whether that is torque catheters or dedicated catheters for calcium, or get comfortable with using more advanced CTO wires with different gram tips and learn techniques to drill through some of these difficult lesions. There's a lot of cross-pollination from coronary technology and tools that we can use for tibial segments that can come in really handy. And lastly, some niche applications for some atherectomy tools and specialized tools for crossing these vessels. Napkin rings lesions and tibial vessels are notoriously difficult to cross and treat. Generally, I tend to favor the 009 tip wires to get through some of these lesions where traditional wires cannot cross, like Fielder XT, etc. They offer you at least an ability to cross through. You can pair them with a torque catheter like Corsair, etc., to sort of like move your way through these lesions, a centimeter at a time. Through and through access with retropedal approach is extremely useful and should be used liberally in some of these cases. And I tend to switch to smaller profile coronary balloons very early on in these difficult cases because of their low crossing profile. And some of these balloons are non-compliant, so they tremendously help getting through them. Before we had better tools, I used to use external 30-gauge needles sometimes for some of these difficult distal lesions, particularly in the distal third of the tibials, where I would have to pepper these lesions from the outside with a wire across to get some luminal gain. Over time, it has moved on to different tools. One of the other tools you can try to use is a micro crown on a CSI if you can get a wiper wire through these lesions and run that through to create channel. And most recently now we have a great tool, Javelin catheter, in our toolkit. So Javelin is a front-facing single emitter for shockwave. And the way you use it is that you still have to get a wire through the lesion, and then you can park this Javelin at that napkin ring lesion that you cannot even track catheters through, and turn the machine on and let it fracture the calcium. So in this first picture, you can see that the lesions, it's essentially a CTO that was difficult to cross. A wire was able to get drilled through this lesion, but nothing else would track. So eventually the Javelin was used to create fractures across this lesion to subsequently allow a non-compliant 3mm balloon to deliver the result that we see on the right-hand screen. The forward cohort study for Javelin involved really complex patients. Fifth of them had renal insufficiency. Most of them were diabetic. They were predominantly CLTI patients. with moderate to severe calcification in almost all these patients. 42% of these lesions were below the knee, and almost the same number were CTOs. And the results were, like, ideally, we like to see less than 30% residual stenosis, which is nearly impossible in calcified tibial lesions like that. And they were able to achieve almost 80%, less than 30% residual stenosis and really complex lesions like this with this tool. So some of the fundamentals for tibial calcific disease is that you want to size your balloons 1:1. Undersizing balloons in these segments really don't help you, because the goal at the end of the day is to prevent post-op dissections, and there's a lot of recoil in these vessels. So liberal use of IVUS and appropriately size the balloons to the vessels is very important. If you're using IVL, then I recommend upsizing by 10% for the balloon. The goal is to have low pressure, prolonged inflation. So I typically do 4 to 6 atmosphere inflation for about 3 minutes for each segment. Drug-coated technology did not really pan out in the tibial space so far. Drug-eluting stents are very useful in proximal tibials, but I would not recommend doing them in mid to distal segments. The optimal sizing for IVL, like I mentioned earlier, is 10% oversized to the vessel for optimal delivery of energy to the vessel, and particularly breaking that medial wall calcification. So even treatment at less than 4 atmospheres can deliver effective pressure up to 50 atmosphere into the vessel wall, giving you good luminal gain in these vessels. Generally, when you are doing these BTK interventions complicated by calcium, in almost all patients, there is about a 30% vessel recoil. So we never stick around long enough to see these patients again 20 minutes later on the table. But if you were to do a tibial intervention, do SFA, you would start noticing more and more of these problems. So that brings me to the next point, that almost all these vessels need to be modified before you start treating them with balloon angioplasty. Excisional atherectomy with, say, Hawk is very effective. You can use that for proximal tibial segments, but it becomes more and more cumbersome as you go to mid and distal segment, especially for very calcified lesions with exophytic plaque. Orbital atherectomy is useful. I mentioned one use for it in napkin ring lesions. It can be complicated sometimes by sludge, which is hard to kind of manage. So you have to be judicious with it. In my practice, I sometimes use the 1.25 micro crown, especially in the pedal loop, if I need to. Laser-based atherectomy is generally at the bottom of my algorithm, but some people love it for calcified lesions. There are some balloon-based treatment algorithms for cutting and scoring that we'll talk about briefly. And lastly, and one of the latest things for us is lithotripsy that we've been using a lot for BTK segments. The BTK2 trial was a multi-center single-arm study that published their 30-day results in fall, and essentially took, again, these really complex CLTI patients who were dialysis dependent, had wounds at baseline, and over 70% of these were diabetic. So real-world CLTI patients without cherry picking, with severe calcification and long segment, 9 centimeter long segment lesions, with a third of being CTOs. And with the use of shockwave lithotripsy balloons, they were able to get less than 26% residual stenosis, which again is phenomenal, with very little stent rate. Some of the other technologies that are exciting and useful in calcified segments are things like Serenator balloon, which has a semi-compliant balloon with external serrated metal trips that leaves these little indentations and fractures in the calcium that help you expand the vessel better with a non-compliant balloon. And their results were also really impressive, with about 17% residual stenosis after ideal inflation with the balloon followed by a non-compliant balloon. Some of the other technologies that are on the horizon and are exciting are things like reflow retractable spur stents that have the capacity even to deliver drug. So we'll wait and see how these technologies pan out. So all in all, difficult space to work in, but limb salvage is feasible, but you have to be very thoughtful about medical management of these complex patients. You have to pay attention to how you cross these lesions in true lumen and be comfortable with alternate access, and really take a moment during the case. I know we are all busy, but really focus on vessel modification for the calcium to get durable results. Thank you.
Great, really thorough, great talk. Every time I hear someone who gives a presentation with all the different wire sophistication, I'm always a little bit jealous. I am far from that sophisticated with wires, but appreciate always hearing to learn a little bit more. Any questions from the audience? Wait one more second, just in case. Dr. Yasa, any questions from you this time?
Yeah, it was an excellent presentation. Thank you. I'm curious if anyone kind of availed themselves of the same technology, for example, in a patient at the more femoral level that you maybe don't want to put through a femoral endarterectomy. I know it's not popular and we are surgeons first, but and off IFU. But curious if anyone, uses similar tools and techniques for those calcified common femoral or proximal SFA lesions that you may not want to make an incision and repair. Absolutely.
I actually have one tomorrow on the schedule. So the guy is cirrhotic. His baseline INR is almost 1.8, 1.9. His platelets, he'll get platelet transfusion tomorrow to get this done, and he has tissue loss. So I don't want to go and do anything crazy. He has a femoral near-occlusive CTO with significant calcific plaque that I'll treat endo tomorrow. Algorithm for me generally is excisional atherectomy in those cases. However, his vessel wall is calcified enough that I'll try shockwave first before I pull a hot, LX or something like that to try to shave some of more of that plaque off and just use a DCB. But
same principles. Are you really truly aiming 1-to-1 in that environment, or are you trying to create a flow channel?
So, for example, I'm just thinking of this patient in my head now. So I'll probably use like a 7mm balloon or a 6mm balloon to create a channel first, almost 1:1 to the proximal SFA, and then I'm going to see what's left behind after the shockwave. If I'm happy with the result and it's enough, I'll stop there with just DCB. If not, then my thought would be to protect the SFA with a basket and perform excisional atherectomy to get more luminal gain, and then balloon it with perhaps an 8 or something like that.
Sounds
not
great.
Denting those segments
Right.
yet. Don't really enjoy that. So anything I can do to avoid a stent in those flexion areas with just vessel modification.
We do have a question in the chat that if we can answer quickly and then move on to the next speaker. Much benefit for using shockwave on non-circumferential calcium.
Yeah.
Go ahead. Chris.
No, I think there's significant benefit there. I think, when it's eccentric calcium on one side, you really are limited with other techniques like orbital, that you really don't get as much impact onto that calcium as much as the negative effect on the opposite wall. So you're really stuck with something like directional. But I think with lithotripsy, it really does give you because low pressure inflation, it really gives you a good result on where the indents in that balloon are, and you can see that balloon slowly expand as the pulses are given.
I would add that you just have to be mindful about delivering more pulses than you normally would for a circumferential lesion or an eccentric lesion when you're treating with shockwave.
Great, thank you. Really appreciate folks dropping their questions in the Q&A section. We're trying to keep track of those. I'm going to keep us moving if you think that's right, Dr. Milner. So love to introduce Dr. Ravi Ambani. He joins us as a vascular surgeon from the Cleveland Clinic. He's been heavily involved in the Midwest Vascular since he was a fellow. Really strives to be an excellent teacher and mentor to trainees and medical students alike. So Dr. Ambani is going to be taking the stage. Thank you.
Thanks for that introduction. Let's hope I can do this correctly.
Looks great.
Working perfectly. All right. Good evening, everyone. As we said, I'm Ravi Ambani. I'm from the Cleveland Clinic. I want to start by thanking everyone for your time and joining us in this webinar. I'm excited to show you how intravascular lithotripsy has really changed how I focus on complex endovascular aortic repairs and how it's really changed my practice. My disclosure is that I do speak for Shockwave. So over the past few decades, we've had a lot of advancements in the endovascular treatment of aneurysmal disease. This has expanded our ability to treat more patients with varying levels of frailty. However, we still remain limited by patients with small access vessels, significant calcific burden, which can both make delivery of large bore endoprostheses challenging. So historically, these patients have required creation of conduits or the cracking and paving of their iliacs to perform a repair safely. Calcified iliac arteries are problematic for a few reasons. First is that the risk of arterial injury, which is either a dissection, thrombosis, or rupture of the vessel, is always apparent. And for those of us who have unfortunately ruptured an iliac, it can be a moment of a little terror, and you need to move quickly. This can lead to significant hemorrhage, and if you don't recognize it promptly, the patients can get quite sick quite quickly. Another issue with manipulating large bore sheets and devices through these diseased vessels is the possibility of embolization. And when you're doing things percutaneously, sometimes these events can go relatively unidentified in the moment if it's a small piece of plaque that embolizes, and these can lead to acute limb ischemic events, which can necessitate further surgery to restore the blood flow. So what options do we have currently, and what exists to treat these patients? As we mentioned earlier, the traditional approaches to patients with poor access include conduit creation, whether that's a direct aortic conduit, an iliofemoral conduit. With the advances in endovascular therapy, we've transitioned now to more of an angioplasty and stenting the vessel. Prior to introduction of these larger devices, the crack and pave method. Sometimes, and I've done this myself, if a device is difficult to advance, especially if you have a sheath already in place, you can coat the device in a hydrophilic lubricant like propofol, and this will allow it to track easier. And while all these methods do have an important role for patients, in my practice, I've found that with the introduction of intravascular lithotripsy, I now have a quicker and more effective method of improving the deliverability for EVAR and TVAR. So how it works. In brief, intravascular lithotripsy works by using a catheter to perform a low pressure inflation across the target lesion. The emitters are then used to deliver sonic pressure waves to the calcium to crack it, as we heard from our other speakers, and this allows for safe expansion of the vessel lumen. So the data is kind of very important in this regard, and it's compelling when you really think about it. The Disrupt PAD3 observational study represented a fairly large prospective real-world data set that looked at heavily calcified lesions in peripheral arterial disease. In their sub-analysis of iliac arteries, 14% of these patients had large bore access cases, and they showed no vessel injury and minimal residual stenosis after use of intravascular lithotripsy. I think as Vipul said, the luminal gain you get is actually the thing that's going to be most important with these patients, and I think the IVL does help a lot in that regard. So although Shockwave has several lithotripsy catheters, and in my talk, I'm really focusing on the iliac arteries. And I think for this, the devices that we're really talking about are the Shockwave L6 and the M5 Plus catheters. For smaller caliber vessels, using the M5 Plus catheter allows us to treat vessels as small as 3.5 millimeters up to 8 millimeters, with the benefit of staying at a smaller sheet size. For larger vessels, and the catheter I prefer for the treatment of iliac arteries is the L6 catheter, which can treat vessels from 8 millimeters to 12 millimeters. As you can see by the graphic, the balloon length and energy dispersion patterns are slightly different in these catheters. And for me, I prefer the shorter and more consistent acoustic peak pressure that the L6 catheter balloon delivers to treat the iliacs. So then, now that we've briefly discussed the challenges calcified iliacs can pose on endovascular repairs, how lithotripsy works, and what data we have that supports its use, the device options available, I wanted to show you a couple of examples of how use of lithotripsy has helped my partners and I treat some challenging patient anatomy. The first patient is a 70-year-old male with a past medical history of bladder cancer and a urinary diversion, PAD, and prior pulmonary embolism. He's found to have a 6-centimeter infrarenal AAA, and as you can see in the videos, he has significant calcifications of his common iliacs and external iliacs bilaterally. His reference vessel diameter was 10 millimeters for each iliac artery, with a lumen size of 4 to 6 millimeters throughout. So the MIP image on the left shows how severe his calcium burden was, and you can see the outline of his calcium or the tracks on his intraoperative angiogram. After using a 10 millimeter shockwave L6 catheter, we were able to deliver a large bore endograft and gain enough luminal gain to advance both the sheaths without any issue and complete our EVAR. And the postoperative imaging shows that we have no external compression of either limb on both the axial and the coronal imaging. So both limbs fully expanded, some mural thrombus in the stent, but palpable femoral pulses after the case, and the guy is doing quite well. So our next case will demonstrate the use of lithotripsy in performing a fenestrated repair. This patient is a 70-year-old male with a past medical history of CAD and a recent PCI, COPD, cerebral aneurysm, and lymphoma that was treated, who has a 5.5 centimeter juxtarenal AAA. In the videos, you can see that he has a severe stenosis of just a left common iliac artery, and the patient had a non-palpable left femoral pulse pre-op. With his other comorbidities, we decided as a team that an endovascular repair was the most suitable for him, but we knew we would have to treat this common iliac lesion. So as any good surgical team does, the first thing we did is cross the lesion and shot a picture. We saw this tight stenosis on the intraoperative angiogram of his proximal left common iliac. We did try to track a sheath past it. However, we were unsuccessful and encountered a decent amount of resistance. So to avoid any additional arterial injury, we decided to treat the segment with lithotripsy. We selected a, as a reference vessel diameter was a little over 7 millimeters. We elected to use a Shockwave M5 plus 7 millimeter balloon to perform several low pressure inflations of this lesion. And as you can see by, I know it doesn't translate super well, but the arrow marks the M5 plus catheter with the emitter shown. So here we can see on the left that there's no residual wasting of the balloon. After lithotripsy, we were able to advance our large bore sheets and complete the ZFAN without issues. The completion angiogram shown, everything was flowing well, no hang up of any contrast, and it looked well. The patient now had the return of a palpable femoral pulse, which was an improvement in his exam. On his 1-month CTA, you can see that the ZFAN looks good. There's adequate seal, renal stents are open. There's no significant, no endoleak noted. The stents are wide open. The left common iliac especially, the stent isn't tapered. There's no external compression. So we were very happy at this result. And this patient, you know, I've seen over a year's worth of imaging, and it still looks great. So I think as we continue to advance our endovascular treatment of patients with aneurysmal disease, dissection disease, any really aortic or iliac pathology, we're going to keep encountering additional challenges, and they're going to present themselves, and we're going to have to learn how to deal with them. Calcified iliacs and access vessels can be cumbersome, and having an algorithm on when and how to best improve your probability of successfully treating the patient is paramount. In my practice, intravascular lithotripsy has positively changed the way I handle these patients and I handle these situations. And for me, it's allowed me to treat more patients with a minimally invasive approach while maintaining safety and efficacy of my repairs. Thank you to the Midwest for allowing me to present today. And I'm also happy to take any questions you guys have. Thanks.
Great. I came off microphone first, I guess. I was looking at Ian, since she hasn't yet. So great, really great presentation. Very thorough once again. And once again, appreciate everybody being so punctual with their talks. I want to just make one comment, and then I do have a question for you as well. So Dr. Bobrowski and I have used this a fair bit for access-related challenges for EVAR, TVAR. And one of the things we've done in our practice a little bit, which we have found reasonably beneficial, because you made a big point about the limb patency, which I think is one of the challenges. So what we've done is use lithotripsy as an ability to be able to get a main body device in, and then brought out as limbs on both sides, balloon expandable covered stents, VBX, as limbs rather than using the limbs from whatever device you're using. And we just felt like that combination does a nice job of being able to treat the aneurysmal disease, but at the same time dealing with the occlusive disease. So we've had pretty good success with that. It's not an everyday case, but it is for some of these more challenging anatomies.
I think it's a super
go ahead.
important point. No, I think that's a great point. And I've had a couple patients that I have had to do that with. And what I usually do is, I think we talked about IVUS already, but if, if it looks like, even if it looks like the contrast is flowing well, I will just, you have large bore sheaths anyway, I'll just throw a, an 035 IVUS up both and make sure the limbs look well next to each other. If there's any signs of compression, even if it's faint, a balloon expandable stent makes a ton of sense for me right there. And I think that helps. It has to help.
Absolutely. I think one of the challenges is, we haven't talked about this very much, is balancing the cost versus the difficulty you essentially may have with a procedure. And one of the questions that I think comes up a lot about the use of lithotripsy for access for EVAR, TVAR type procedures is, should you just try to pass a device first, and then if you're unsuccessful, go back and try shockwave? And what's your opinion of that? Or when people ask you questions like that, what is your suggestion?
Yeah, I think the first thing is, and I'm on the PEC here, so I do look at these things a lot with cost. I think cost is always important, right? I think the one thing Shockwave did is they introduced the E8 catheter, which is nice because you can treat a longer segment with less catheter use, as Talia was saying. Now, in terms of cost for an EVAR, I think the thing that I always think about is, what's the safest thing to do? I think you can try to send a sheath or a device up, but worst case scenario, now you bring and I've had this happen to me during an emergent TVAR, where I did try, because it was an emergency, and also the anesthesia was like, "What'd you do?" I was like, 1 second. So I put my sheath back up, then I had to get a vibe on ready, pull sheath back. And yes, it's possible, but it definitely changes the whole dynamic of the case for that couple of minutes. So yes, you can try to deliver things through, but I think the risk of doing that and getting stuck or having your device not track and injuring the vessel is high. So in my opinion, if I see we have a pre-op CT, we're gonna have an angiogram. If the catheter goes up with a little bit of difficulty, I'm just jumping right to shockwave, because I think it's the safest option. It does add some case, but overall, I think if the patient does well, then that's probably the most important thing here.
Perfect. Ines, any other questions or?
Yeah, thank you. One of my questions about those, really circumferentially calcified aortic bifurcations, are you any experience, or would you suggest bringing up kissing shockwave balloons in those situations so you can get that gain for the limbs? Yeah,
so that's actually exactly what I do. So I take in those, I try to just get, so I'm going a little bit off of the recommendation of the 1-to-1, and I'll take 2 8s. I'll come up from both sides, I'll kiss them, and I'll essentially use all the energy to try to get a luminal gain. If I don't think that bifurcation itself is super tight, like a napkin ring, then I will just take 1-to-1, and I'll go up one side, and then I'll take that same catheter and go up the other side in a more cost-effective manner. But if I have to, then I'll just kiss, because I do think then it's almost like you're doing an angioplasty of a, we talked about coronary vessels again. Their literature is pretty good that, if you size your kissing balloons well in a branch point, you can get a better luminal gain.
So, Ravi, thank you very much. I think we're going to go into our last talk, so we have an appropriate amount of time and then have some time for questions as well. So our last speaker this evening is Chris Pepsiski. Chris is a vascular surgeon at Christ Hospital of Heart, where he's been since 2017. He has a huge interest in minimally invasive treatments, both arterial and venous disease, and is involved with both the limb salvage program as well as the comprehensive vein center. Chris's topic that he's going to be talking about is new technologies and crossing strategies in heavily calcified fem-pop lesions. Chris, thanks for joining this evening.
Thank you so much. Let me get this up here. How do I look there?
Blank.
Blank.
Moving dot, like a cat, something a cat would follow.
Cute pick. That looked promising for a second there.
How about now?
I hate to tell you no. Don't you hate that?
We saw our slides earlier, didn't we?
I know. It's just part of the Zoom fun. It's like
All right,
staying on mute after being on Zoom for 5 years.
Dr. Milner, in the meantime, can you answer a question for me? What are your thoughts on juxtavisceral calcific disease and shockwave, typically treated with endarterectomy, like aortic endarterectomy, those kind of lesions?
Yeah, it's an interesting question. So I haven't had much experience with it in that location. I've done infrarenal. You're obviously asking juxtarenal for a specific reason, which I understand. So I'm not completely trying to avoid your question. I think going to the points that were made earlier in Talia's presentation and your presentation, some of these patients are just going to be so super high risk that you're not going to want to do an open aortic operation. And if they have a strong need to intervene, then I think it's reasonable to consider that. I think if they are a reasonable surgical candidate, you probably still should consider that in that region of the aorta as your first line therapy, I think. But you're obviously asking for a reason. So you have a different opinion?
No, I don't have an opinion. I'm just wondering, with all the advancements, there are a few patients where you have to, wire the renals, protect them, and do all those things, and shockwave, and you can buy them some time, but obviously, nothing replaces debulking, so to speak, for some of those segments. So
yeah, I think that's fair. And I think to your point, and even like when I've done it in an infrarenal location, it's always been with the concept of doing something along the lines of a CRAB or some sort of covered stent technology within there. So you're pretty limited with in your visceral segment. If you'd ideally like to get something to open up in there, and I don't necessarily want to put a bare metal stent across all that, because I think that's going to make anything down the road difficult as well. So, it's a hard part of the body to treat without a doubt. And I think your questions are really good questions. Oh, Dr. Muck is asking the unwanted question, but we can talk about it since it's a appropriate webinar to do that. What do people think about IVL with carotid interventions such as TCAR? Does it make a difference?
Love it. Except they need to give us a 540 and a 640 balloon, Dr. Muck. So we published our results for shockwave and TCAR.
I'm going to stop you just for 1 second, just so I can do the appropriate housekeeping, which this is a completely off-label use of the technology. And you're allowed to talk about your personal experience, but it's completely off-label use of the technology. But go ahead.
Yeah, so we had good results for our small series, but I think the limitation for TCAR and IVL is that we don't have appropriately sized balloons available, which I think will be available soon as a part of a trial that's coming up.
So I think obviously, as everybody knows, it's gained a little bit more popularity, I think, for some of us. I think there was a little bit of concern when that recent paper came out that had the neurologic complication rates that were higher than we expected to see and were high with TCAR and Shockwave. But I think there is, just like we talked about, some of our patients that just for whatever reason you think can't be appropriately treated any other way, and it is something to consider for sure. Do anybody else on the panel, without getting people in trouble, have experience or opinions they want to share with that?
I think one of the challenging parts of using Shockwave with TCAR is the length of the wires, right? So you have to exchange the wires. But in theory, they're actually working on that. But, you know, the concept of treating the vessel and preparing it for the stent is, you know, an ideal but off-label use.
Yeah. Someone else was about to say something, I think.
Yeah, I think for this one, I think I'm like the opposite. To be honest, I do a lot of endarterectomy, and if it's like that calcified, then I'm just gonna do an endart. I think a lot of people, even if they're sick, can get through an endart pretty well. And I do them under general anesthesia, so I'm like taking the most risk, I guess. So yeah, I see the appeal. I haven't convinced myself to try it yet.
Yeah, totally fair. Chris, you're loving it right now, aren't you, buddy? And Dr. Muck followed up his question, by the way, saying there's always one in the audience, and he is spot on. There is always one in the audience like Dr. Muck. It's usually Dr. Muck.
I think the paravisceral discussion is actually pretty interesting because I've had this with my partners recently. I know one of my partners has done a couple. I had thought about doing it on a couple, but I ended up not. But the question's on, do you protect the SMA in one renal? Do you protect more than those? Do you not protect any of them? And then I guess when I think about this stuff, the one I was gonna do is I went very old school and I got pullback pressures, and there's really no difference. And I'm like, and I IVIS, I did the whole thing, and I'm like, okay, like, am I really defending what I'm doing here?
Yeah.
And my question is, are those microchannels enough to just make an aortic velocity flow through it, like take care of the problem? And I don't know. It's hard. I think the one that my partner just did, the IVIS did look a little different on both pre and post, and I'm hoping that that patient does well. I'm sure they will, but it's interesting because you create just a little bit of space, but is that all you need? Because you're dealing with an aorta, you're not dealing with a leg.
I think I'll do the obligatory here, Ross, off IFU reminder. We can certainly talk about our own personal experiences. I will say, I think your assessing of pullback pressures, very reasonable thing to do. I mean, I think sometimes we get really fixated on our own bias that this must be causing a problem, or must be the etiology of the problem. So I think, certainly when we're talking about higher risk interventions like that, being judicious and making sure. I have a bias that I would typically try and protect at least one renal in the SMA, if I can, in those types of situations. But, certainly in those patients who open revascularization is really not an option, and you're fairly confident that this is causing some significant occlusive symptoms. So it's a reasonable approach. I think it also behooves us to remember that if the thing that we're trying to solve is a renal malperfusion, there's the old-fashioned axe by fem to get yourself retrograde perfusion around a poor flow to the renal arteries, for example. But if you're right in that area, it's a good tool to have in the toolbox, but certainly be judicious about its use.
You see my slides now?
No, my friend.
I tried logging on my phone, doesn't work either.
I don't know. Well, you know what? We're starting to bump up on the hour anyway, and I know you worked hard to present this, but to put the presentation together, do you want to give us highlight Cliff Notes version?
Yeah, really for the FemPop segment, there's a lot of tools and options that you can really tackle those, and you just have to be careful with calcifications in the FemPop segment because, as we know, there's complications that can happen with that severe disease and embolization and vessel recoil and failure of stent expansion. We've talked about all those type of things, and there's a number of good crossing algorithm treatment algorithms we learn in training and we gain experience with. But I think in my practice, I've really started beginning to use IVUS on almost every single case to really get a good idea of that plaque morphology, both proximal and distal cap and within the disease itself. And I find that these vessels have a lot more calcium than you would expect. And there's a lot of options for crossing those CTOs. And as long as you know what your lab has available and know what the risks and limitations of each device are and use what you're comfortable and skilled with, I think letting IVUS guide you on how to treat that really will open your eyes on the best types of therapy for that. But for me, lithotripsy for these FemPop calcific lesions below the knee, iliacs, we've talked about it. Lithotripsy has really been a game changer for me. And I like it because I'm very risk averse. If these patients are truly high surgical risk, that they're not a FemPop candidate or a bypass candidate, they're probably have minimal tolerance for complications endovascularly too, because these are patients with multi-level disease, single vessel runoff or minimal vessel runoff. These are patients that if you're embolizing, if you're too aggressive with atherectomy, you're really going to lose that limb. So if you're able to get a wire across, and that's all and good, but what if nothing tracks? We've all had those cases where you work so hard just to get your CTO wire through, and then you try to exchange out with a catheter or do IVUS, and nothing tracks. That's really when you can turn to the Shockwave Javelin to really open up a channel of flow for you as that forward-facing emitter. It's only a few millimeters from the tip, and you're able to bury that emitter into your proximal cap and kind of let the pulses do their work. Because I generally try to use lithotripsy for most of these calcified lesions, but the balloon-based platform is a little higher crossing profile than your normal PTA balloons. So Javelin's a great option to really open up some of those microfractures within the calcium and allow you to deliver whatever further therapy IVUS tells you need to do. The Javelin catheter is pretty flexible. It's hydrophilic, but it's got some good support. So when you're really pushing forward, you're not going to get too much buckling as long as you're careful. I think with the key with the Javelin is slow and steady pressure. Let the Javelin do the work. Don't force it. Don't peck it back and forth and daughter it too much. Just kind of forward pressure. You only have 120 pulses on this current generation. Hopefully we'll get a few extra pulses with future generations to be able to treat longer segments. But using the Javelin, then I can IVUS. Then I usually will follow up with further balloon-based lithotripsy to really just fully expand those femoral popliteal lesions. Had a couple cool cases to show you. Can send out the slides afterwards, but I apologize for that. It did work beforehand, so it's got to just be me. But
It's all good.
I think that in summary, these calcified lesions, very challenging. They're definitely at risk for complications, even though you're trying to keep these cases minimally invasive. I use IVUS to really direct my treatment plan and know your tools. And I really think lithotripsy is highly effective for these calcified lesions. And I'll pull out forward IVL when I can't get anything through the lesion. And I'm not sure I want to turn to something more aggressive like laser or orbital atherectomy. So
Awesome.
thank you for the invitation.
Yeah, well,
I
thank you for
appreciate it.
ad-libbing. You did a great job giving us a good summary. So, and I'm sorry you had the slide issue. It's all good. I know it's frustrating, like you prepare in advance and this happens, but nice job. We're actually coming up on the hour anyway. Is there any pressing questions from anybody? All right, I'd like to just say my thanks to the speakers. Everybody really did a fantastic job sharing their experiences, and would like to thank Shockwave once again for helping support the educational mission of our society. I think it's something that we're a real strength of ours, and I appreciate that. And Enos, I'll turn it over to you to finish, please.
Thank you so much, and thank you to all of our speakers. Thanks for everyone who joined, and Stay tuned for the next version of this. I'm sure everyone will pay attention to your email in baskets. These talks are always really educational, and I'm so appreciative to all of you for sharing your experiences. Thanks for having us.